Hi, everybody. This is chapter 30. These are drug therapy for osteoporosis, arthritis, and skeletal muscle relaxation. And this starts on page 469. Now, when we're talking about osteoporosis, this occurs with normal aging. Everybody's going to have osteoporosis sometime in their life, but we try to do preventive measures and do things to prevent that from occurring. You're going to see it more in women than you're going to see it in the male population. If you have a family history, that puts you at higher risk for osteoporosis. If you smoke, osteoporosis. Corticosteroids, if you use it daily, especially those people who have a lot of those autonomic diseases, can cause a lot of issues. So corticosteroids used daily can cause osteoporosis. If you have decreased levels of androgens, and those, remember, are in the men, and estrogen in the women, that can also put you at risk for osteoporosis. And another thing that causes osteoporosis, if you don't do any weight-bearing activities like walking, dancing, running, or resistive exercises. If you don't do any of those things, that can also put you at risk for osteoporosis. Osteoporosis will increase your risk for bone fracture, and it can also cause postural changes. So a lot of times you'll hear people say, I shrunk. It's because of osteoporosis. So it can cause decreased height. Now, there are types of drugs to manage or slow down osteoporosis, and that's what we're going to talk about. The first thing we can do is use nutritional supplements, all right? And that would be like calcium, but remember, when we have calcium, we need to make sure we have activated vitamin D. In order for them to work, those two need to be given together. So you need calcium with activated vitamin D in order for it to work. So we can use that. Another thing we can use is the biphosphonates. Those are some we can use. We can use the estrogen agonist and antagonist, and we can use the osteoclastic monoclonal antibodies. Okay, so those are some of the ones we can do. Now on page 472, those are the common meds for osteoporosis of the different types. And alendronate, Fosamax, we give a lot of that. Ibandronate, Beniva, give lots of Beniva. Rolifexine, Avista. Those are probably the biggest ones that I've seen. I have seen the other ones, but those are probably the ones that I've seen most often. So those are the common ones. So when we're talking about the first one, the nutritional supplement, like I said, calcium is a mineral. It is absorbed in the small intestine only if we have the presence of activated vitamin D. If we do not have activated vitamin D, then it will not get absorbed in the small intestine. We need activated vitamin D to absorb adequate amounts of calcium. Vitamin D and calcium, they both need each other. So that is the first one that they can try is nutritional supplements. The second one that we're going to talk about is the biphosphonates. The generic name has Drone, D-R-O-N, in the middle. It is calcium modifying drug. It's less effective in men, so it's not usually prescribed for the male population. Other uses prevent skeletal fractures with patients diagnosed with bone metastasis or any multiple myelomas in Paget's disease. And it treats decreased calcium levels in cancer patients. So besides using it for osteoporosis, it will also help decrease fractures with cancer patients that we have to be concerned about. It's effective for patients who have adequate intake of both calcium and vitamin D, so it's going to be more effective if you have an adequate intake, and it's not to be used in children. So that is one of the things, it cannot be used in children. Now, the third one is our estrogen agonist and antagonist. For osteoporosis, the progress is more after menopause because your estrogen production is decreased. So the estrogen and estrogen agonist help prevent bone density loss, and that's what we want. It will help prevent that. Problem is that estrogen agonists activate estrogen receptors in all tissues, which will lead to tumors. It can lead to tumors in the breast and also in the uterus, and it will increase clot formation, and it will cause a thickening uterine wall lining, which can cause dysfunctional uterine bleeding, which is not uncommon. So that is a big problem with the estrogen agonist and antagonist. It can actually cause some tumors as well as increase clots and make the wall of the uterus thick, and that can cause dysfunctional bleeding. Estrogen agonists and antagonists are selective in the receptors they activate, and they will block these problems if you have a decrease. So we will give them to help manage osteoporosis after menopause. So your estrogen agonists and antagonists, mostly you're going to see given and prescribed to females after menopause. Excuse me. So that's that one. Now the fourth one is our osteoclast monoclonal antibodies. Now these antibodies, they bind with immature osteoclasts, and it prevents them from maturing to reduce their action of decreased bone density and strength. Because they are composed of antibodies, they can cause severe allergic reactions. They are only prescribed for severe osteoporosis when other treatments have failed. So this osteoclast monoclonal antibodies, so you know they have to be composed of something, human or animal, so they're going to cause the big allergic reactions. So these are the ones that we give at least the last resort, last resort. So the goal of osteoporosis meds are to maintain bone density and strength. Blood calcium levels will remain normal, and the biggest thing is no bone fractures occurring, and that's what we want. But these medications do have side effects. Now the biphosphonates can cause abdominal pain, can cause headache, esophageal reflux, and nausea. Your estrogen agonist and antagonist can cause muscle spasms, nausea, and indigestion. And your osteoclast monoclonal antibodies can cause skin rashes and musculoskeletal pain. Now, adverse effects. Your biphosphonates, jawbone necrosis, or osteonecrosis. And you're going to see more if they had any dental work that involved the jawbone. Okay, so jawbone necrosis or osteonecrosis. You're going to see more if they're taking high doses, or if they take an IV dose, you're going to see it more happen. So that's with the biphosphonates. Now your estrogen agonist and antagonist, we already talked that it will cause an increased risk for clot formation. So guess what? You're at increased risk for DVTs, deep vein thrombosis. You're at risk for strokes. You're at risk for myocardial infarct, so a heart attack, pulmonary embolisms, so clot in the lungs. So you don't want to give to anyone with any clotting problems, or if they've had a stroke or a heart attack in the past. We definitely do not want to give that medication because it can make things worse. And last are osteoclast monoclonal antibodies. We already talked about causing allergies because of made of some type of human or animal component. It can cause severe allergic reactions, can cause anaphylactic issues. So it also puts you at risk if you do more than one dose. So if you repeat the dose, that puts you at higher risk for having these allergic reactions. And it also can cause that jawbone necrosis, especially if you just had dental work and it involved the jawbone. We want to teach our patients with the biphosphonates, early in the morning you need to take it, early in the AM. You want to make sure after breakfast with a full glass of water, stay in an upright position for 30 minutes after to prevent esophageal reflux or irritation. So early in the morning, you want to take this. Report to the dentist before any procedures if you're taking any bisphosphonates or osteoclast monoclonal antibodies, because you want to make sure you prevent that jawbone necrosis. So those are some things that you want to teach the patients about this. But remember, they have to stay up in an upright position for biphosphonates for at least 30 minutes after to prevent that reflux. So those are dealing with osteoporosis. Now, the next thing we're going to talk about is arthritis. Arthritis can be very detrimental, a lot of pain and issues that can be occurring for the individual. So we do try to give some medications to prevent the increased issues with it. So with arthritis, we are talking about different things. We have the osteoarthritis. You can have rheumatoid arthritis, psoriatic arthritis, and gouty arthritis, which is due to gout or gout. So the types of drugs to manage arthritis, we want to definitely use for pain medications. You can use pain meds for acute episodes to help with pain. Only it will not help with the disease process, but it will help with the pain issues. So sometimes you will have to take some over-the-counter pain medication or prescription pain medications to help with the pain. But just remember, it's not going to do anything with the disease process. The second thing they can use is anti-inflammatory drugs. And we've talked about anti-inflammatory drugs. These will reduce or slow the tissue damage and the symptoms of arthritis. Usually prescribed, we will prescribe the NSAIDs, which are our non-steroidal anti-inflammatory drugs. We can use corticosteroids, and we can also use DMARDs, or disease-modifying anti-rheumatic drugs. So those are the things that we've talked about these in the past chapters, but the second thing we can use is anti-inflammatory drugs to help with slow down that tissue damage and the symptoms of arthritis. So far we have pain meds, anti-inflammatory drugs. That we can use. Now, the third, we can use drugs for hyperuricemia and gout. So these are for people who have gout. And on page 475, allopurinol. Probably allopurinol is the biggest medication we use for gout. That is probably number one, but for people who have gout, it's a buildup of uric acid in the system. It goes mostly, they'll have complaint of pain in their joints, like in their fingers, their elbows, their toes. You always hear that gouty big toe. And it's big, they swell up and it gets red and inflamed and very painful. So they will be put on some of these medications for it. Now, uric acid synthesis inhibitors, they will prevent the formation of the uric acid, which makes that gout. They also have the enzymes, which will increase uric acid excretion, and we use when uric acid levels are really, really high. So the uric acid synthesis inhibitors, like the allopurinol, we'll use to prevent the formation of uric acid. And if they have an increase, a lot of uric acid in them, then they will use the enzyme in order to bring it out. And that will make the uric acid get out quickly. And, so you use when the uric acids are really high and you need to decrease it quickly. So you can't really be on it for a long period of time. It does not prevent gouty arthritis. It is used in cancer patients to decrease uric acid related to cancer therapy, especially the tumor lysis syndrome. So it is used for that. But like I said, usually the pills are first, then we use the enzymes for bigger ones. The goals of gout meds are to decrease pain, swelling, and redness, increase that physical function, and decrease joint damage. That's a big thing that we do not want occurring. Side effects for our gout meds, uric acid synthesis inhibitors can cause headache, rash, and nausea. The enzymes can cause rash, abdominal pain, mucositis, and nausea. Adverse effects for our gout meds, rare for uric acid synthesis inhibitors, but it can put you at increased risk for myocardial infarcts, heart attack, heart failure, strokes, especially when you take with uric acid synthesis inhibitors for a long period of time. And that would be the enzymes we're talking about. Now, the enzymes, they do cause hypersensitivity reactions and anaphylactic reactions. So those are some things that you have to watch for. A lot of times when we do give these medications, because they are IV, we want to make sure we have emergency medical equipment at the bedside, because it will take to infuse, sometimes like even after 2 hours after infusion, you can have an allergic reaction, especially that anaphylactic of hypersensitivity. So we want to make sure bedside equipment, emergency equipment at the bedside at all times. It is contraindicated, the enzyme meds for Black population, especially if they have that deficiency of the enzyme glucose G-phosphate dehydrogenase, the G6PD. We definitely do not want to give that to them because it is contraindicated. We want to teach patients, very important, if you're taking allopurinol, take it with a full glass of water, okay? Take it with a meal, okay? You have to make sure drink plenty of water with allopurinol. Uric acid synthesis inhibitors, good fluid intake, especially water throughout the day. You want to teach them that. It's very important to make sure. So if you're on it, lots of water throughout the day. Pregnant and breastfeeding population is not recommended for pregnancy or breastfeeding. That's something to talk to the OBGYN about. So that's basically when we're dealing with, um, you know, medications for gout. Now, when we're talking about muscle spasms, that's another thing. There are three types of skeletal muscle relaxants. We have the carbonates, which is on page 477, the common dosages. We can use the cyclobenzapines, and we can use benzodiazepines. And we talked about it back in chapter 28, the benzodiazepines, when we talked in there. So we've had those. Now, we're talking about the carbonates, methocarbamol, Robaxin, and cyclobenzaprine, which is Flexeril, are probably the biggest muscle relaxers that we give out there. Big muscle relaxers. These drugs do help with skeletal muscle relaxing. It will decrease muscle spasms. We also use them for sedation. It helps people at night sleep. And we talked about that when we talked about insomnia. Pain relief, and it also will increase mobility function of the muscle, and that's what we want. But they do have side effects. And the side effects, remember, they work on the central nervous system. Okay, so our side effects will be things that work on the central nervous system. So our carbamates can cause flushing, hypotension, bradycardia, and fainting. Flushing is a normal side effect that occurs with these medications. Your cyclobenzapine can cause dizziness, headache, anticholinergic effects like dry mouth, blurred vision, and urinary retention. So if they cause those anticholinergic effects like dry mouth, we want to make sure we teach them about good oral hygiene, chewing the sugarless gums, mouth rinses. Blurred vision, we have to be careful with our patients with glaucoma because of the intraocular pressure. And urinary retention, we need to monitor, especially our male populations who have BPH, because that can cause issues with them, or anybody who's having urinary retention issues. Adverse effects, the carbonates can cause amnesia and angioedema. So we use cautiously with seizure patients because it will also decrease the seizure threshold. So not good for our seizure patients at all. If you give IV, we always are going to watch for infiltration, any pain, swelling, any sloughing of the skin at the injection site. We're going to be watching for that. And our cyclobenzapines can cause cardiac dysrhythmias, prolonged cardiac conduction. So we do not want to give to anybody with a known cardiac history. We don't want to give to patients taking any MAOI drugs because it can cause severe hypertension and the serotonin syndrome, which we talked back in chapter 27. And we don't want to give to seizure patients because of the lowering of the threshold. So don't want to give any cyclobenzapines to any seizure patients, as well as anybody with carbamates, because it will lower the seizure threshold. And if that's the case, they will have to adjust the patient's seizure medications. So before we give these meds, we always want to check the level of consciousness. We want to know their cognitive function. We want to know their skeletal muscle reactivity. We're going to ask if they have had a history of seizures, if they're on any medication for seizures. Before we give any cyclobenzapines, we're going to assess the blood pressure and heart rate and the rhythm and notify of any irregularities and any heart rhythm changes. First dose, you will notice a problem with the blood pressure or irregular heartbeat. And if that does occur, you want to hold the dose and call the physician about it ASAP. But usually at the first dose, you're going to notice a problem with the blood pressure or an irregular heartbeat. That's why it's important beforehand to assess that blood pressure and heart rate and to make sure we assess it afterwards, because usually at the first dose, you're going to notice problems. Afterwards, we're going to recheck the level of consciousness. We're going to check the muscles. Are they more relaxed, or if you're having any weakness? You can become drowsy, so you're at risk for falls. You can have a decreased blood pressure, so positional changes you have to monitor. It can cause urinary retention, so we have to monitor patients with prostate problems. And IV meds, we're going to watch the site. And of course, with our cyclobenzapines, we're going to assess the pulse every hour to check for any skipped or irregular heartbeats. after the first dose and call the doctor with any changes. Check that blood pressure for increased blood pressure and notify also the doctor. We're going to teach the patients usually for short term. Usually we use it for 2 to 3 weeks. It can be very habit forming and that is not good for people. So that's why it's only good for like 2 to 3 weeks. It can sedate patients, so you have to be very careful operating heavy machinery, doing anything outside. So make sure you take it working around your schedule and avoid alcohol at all costs because it will increase sedation and we do not want that. Cyclobenzapines, you need to check your pulse daily for any irregularities, and if they are irregular, you need to notify the doctor. Chest pain or any type of shortness of breath, it's always call 911, get to the emergency room ASAP. And of course, cyclobenzapines are not good for the sun, very photosensitivity, so you want to make sure that you wear lots and lots of protection, wear hats and sunscreen and all. Pregnant and breastfeeding population, if needed, can be used in pregnancy. It can pass through the breast milk. If you do breastfeed, you need to watch your infants for drowsiness and GI problems. So not the best thing to breastfeed, but always talk to your OBGYN and the pediatrician. In our older population, carbamates are not recommended. They are at high risk for falls due to muscle weakness, and very, very use caution when given cyclobenzapines to our patients, our older populations. So we need to monitor them very closely. So that is chapter 30, osteoporosis, arthritis, and skeletal muscles. So any questions, you know what to do and where to find me.